Hello, and welcome to Working with Clients and Families with Co-Occurring Disorders. My name is Dr. Deborah Hendren, and I'm a substance abuse counselor in Maine, and I also teach in New York State. It's wonderful to have you with us today. Our resources come from Samsha, Hazelden, Dreamtime Photos, and Joel DeLuca, PhD, and Hazelden. Our learning objectives will be how to understand co-occurring disorders, how to develop and use therapeutic alliances to engage the client and family in treatment, and how to maintain a recovery perspective, how to monitor psychiatric symptoms in clients, how to use supportive and empathetic counseling, how to manage countertransference, how to increase structure and support with contingency management and exploring client spirituality. And there's addendums on domestic violence and suicidality, and we're listing some best practices for effective therapies. The term co-occurring disorder means a mental disorder that coexists with at least one substance use disorder in an individual, such as cocaine dependence and bipolar disorder. Patients in treatment who have co-occurring disorders exhibit behaviors or feelings that sometimes interfere with treatment. In other words, they might have an increase in mental health symptoms, which may cause them to relapse, or their relapse may be due to not being on medication for undiagnosed mental health symptoms. Symptoms also indicate the presence of both independent disorders and self-induced disorders, along with substance use disorders. So back in the day, we said it was CAMI, chemical abuse, mental health disorders, where we weren't sure which came first, the chicken or the egg. Now we're treating both in the substance abuse community. So we're going to learn about screening for co-occurring disorders with the client and the family, and then with the family themselves. So for the client family, we use a psychological assessment tool. We use an SSI, or simple screening instrument. We use motivational interviewing, Beck's depression, ACOK, and psychiatric assessments for psychiatrists, and the ACEs. And then for the families, we do a simple family assessment, use motivational interviewing, cultural assessments, domestic partner and child abuse assessments if necessary. So signs of tolerance build in co-occurring disorders within the client and the family. So the use of substance or mental health symptoms increase, and for the client and the family, the acceptance of loved ones' mental health status or addiction increases. There is a denial of the problem in both the client and the family, and both the client and the family want to appear to feel normal. There is irrational thinking, and mental instability increases in the client, and for the family, emotional attachment to the loved one's problems increases. They become more concerned with the client and what they're doing to help their problem. Addictions increase in the client, and addictive behaviors such as denial, rationalization, projection increase in the family. And engage in high-risk behaviors for the client. They may, stay out all night drinking and come home, and the family member is worried, and they say, oh, I was working late and I fell asleep at work. And then the family tends to believe the unbelievable. So they believe that the lies that the client is stating are true. And the client attempts to control the addiction and mental health symptoms by using other drugs, by using more drugs, by using less drugs. And the family attempts to control by making threats and ultimatums to the client, by telling them to get out of the house or go get help, or they're going to call the police, If they drive, there's all kinds of threats and ultimatums made to the client. So the important thing in treatment is to begin to develop a therapeutic alliance to engage the client and the family in treatment. Research suggests that therapeutic alliance is one of the most robust predicators of a treatment outcome in psychotherapy. So there are things that we can do that create that therapeutic alliance, and we're going to look at them. But one of the big one is to be non-judgmental, nurturing, and to have understanding of the client's problems. So the steps to use to develop a therapeutic alliance are demonstrating an understanding of the acceptance of the client and the family's problems that they might face. Help the client family clarify the nature of their difficulty. Indicate that you, the client, and the family will be working together in a partnership. Communicate to the client family that you will be helping them to help themselves. Express empathy and a willingness to listen to the client's and family's formulation of the problem. What do they think is wrong as opposed to what do you think is clinically wrong? Assist the client family to solve some external problems directly and immediately. Foster hope for positive change within the client and the family. So maintaining a recovery perspective, there's varied meanings of the word recovery, and it has different meanings in different contexts. And substance abuse treatment clinicians may think of a person who has changed his or her substance abuse behavior as being in recovery for the rest of their life, although it's not necessarily so in formal treatment forever. Mental health clinicians, on the other hand, may think of recovery as a process in which the client family moves towards specific behavior goals through a series of stages, and they learn coping skills for their mental health symptoms. Physically, doctors may think it being in recovery is a remission period for the client. So for the recovery perspective, we take a lot into consideration. We consider health care. What does the client do to relax? Do they have any relaxation skills? What is their home environment like? What is their working environment like? Do they have proper hygiene and body care techniques? Do they have a fitness program? Are they receiving adequate nutrition? What is their mindset towards treatment and towards recovery? Who are their important relationships in their lives? Get them to describe who their family is. Stress management. Do they have any stress management coping skills? Do they participate in any sport or fitness or relaxation teams activities? And what is their value system? So this is an important slide, the stages of change and the stages of treatment. So I'm going to be using my pen here a little bit to help you. In pre-contemplation, which is the first stage of change, you don't acknowledge that there is a problem behavior and that needs to be changed. In early treatment, we see that pre-contemplation is tied to early treatment. And in early treatment, our job is to instill hope, universality, imparting information, altruism, corrective recapitulation of the primary family group learning, and problem identification. The next stage of change is contemplation, and that's when the client starts to acknowledge that there is a problem, but they're not yet ready or sure of wanting to make a change. This can be seen in both early and middle treatment. In the middle stage of recovery, as the client family experiences some stability, the therapeutic factors of self-knowledge and altruism can be emphasized. That you can develop leadership opportunities for this client, having them mentor new clients, giving them group leadership responsibilities. In the preparation determination stage of change, which is getting ready to take a change, which can again be seen in early and middle treatment, is the part where they are starting to experience what those group leadership responsibilities look like. They're starting to be determined. They're voicing the need for change. In the action willpower stage of change, which is changing behavior, that's usually seen in middle and late treatment. And during the late treatment is also referred to as the ongoing maintenance stage of change. The client family works to sustain the attainments of the action stage. So they do the work, they put their feet to the pavement, they are going to meetings, they are using their coping skills, they are going through trial and errors, they are describing their emotions to you. And they're starting to anticipate and avoid tempting situations and triggers that set off a renewed substance use experience. So they're starting to develop their own personal relapse prevention plan and use that. The maintenance stage of change is usually seen in late treatment and discharge or aftercare. And that's maintaining the behavior change. That's when they've been sober for 6 months to a year. And what happens is in discharge and aftercare, the client family is exiting the treatment modality with a safe plan and skills needed for recovery and continued progress. So they are walking the walk, they are doing the deal, they are in the maintenance stage of change, and they have their client and family support behind them. Now, if we look here, relapse is different, okay? The relapse stage of change is returning to the older behaviors. However, my highlighter isn't working great, is returning to the older behaviors and abandoning the new changes. So if we relapse, what happens is we have to go right back to square one in both stages of change. We return to pre-contemplation and to early treatment. So the relapse stage of change takes us off the wheel of change and puts us back at step one. So how do we maintain a recovery perspective? What are the common co-occurring disorders in patients who are addicted? We see major depressive disorders, dysthymic disorders, bipolar disorders, generalized anxiety disorders, post-traumatic stress disorders, social phobias, obsessive and compulsive behavior disorders, panic disorders, ADD and ADHD, schizophrenia and other psychiatric disorders, cognitive disorders, eating disorders, impulse control disorders, pathological gambling, sleep disorders. There are personality disorders that are associated with, more commonly with co-occurring substance use disorders, antisocial personality disorders, borderline personality disorders, and narcissistic personality disorder. So maintaining a recovery perspective, principles for practice is develop a treatment plan that provides for a continuity of care over time. We recognize that treatment may occur in different settings: residential, outpatient, mental health offices, self-help. Much of the recovery process is the client family driven and occurs typically outside of the professional settings. The counselor should always reinforce long-term participation in these consistently available settings. So principles for practice continued, we devised treatment interventions that are specific to the tasks and challenges at each stage of this co-occurring disorder recovery process. So we use treatment interventions that are specific to the tasks and challenges faced at each stage of change: pre-contemplation, contemplation, preparation, action, maintenance, and relapse. We develop a relapse prevention plan when a client relapses or perhaps before. Many companies devise a relapse prevention plan day one. That's what I do with my clients. Use stepwise approaches in developing and using treatment protocols. In addition, markers that are unique to the individuals, those related to their social, cultural, or spiritual content should be considered. Do they get filled with a feeling of satisfaction when they go to a church or faith-based meeting? If so, that can be part of their recovery plan. It is important to engage the client and family in defining markers of progress that are meaningful to them at each stage of recovery. So let them know what stages of change they're in. Let them know what stages of treatment they're in. They will see this progression and want to attain a higher standard for themselves. So step 4, work with your psychiatrist or your nurse practitioner to monitor psychiatric symptoms. In working with client families who have co-occurring disorders, especially those requiring medication or have been receiving therapy from a mental health service provider, it's especially important for the substance abuse counselor to participate in the development of the treatment plan and to help monitor those psychiatric symptoms. At a minimum, the clinician and psychiatrist should be knowledgeable about the overall treatment plan to permit reinforcement of the mental health part of the plan, as well as the part specific to recovery from addiction. Use specific goals and objectives for mental health that are both measurable by the client for visits with the psychiatrist and the clinician. So, in monitoring psychiatric symptoms, as clinicians, we have a little bit of work to do with the family and the community. So we have to educate family members of both the symptoms of addiction and mental health. We have to educate family members about medication use, storage, and side effects. We have to regularly check in with the family members to provide support and feedback. This is when releases are signed to do so, of course. For the community, we have to educate the client and family to symptoms of both mental health and addiction diagnoses and how that affects them in the community at large. We have to educate about medication, storage, and side effects. We have to teach coping skills for acceptance and commitment therapy, cognitive behavioral therapy, rational emotive behavioral therapy, dialectical behavioral therapy, and other coping techniques. We have to assist the client family in communicating these symptoms and feelings so they feel more a part of the community at large. Step 5, use supportive and empathetic counseling. As supportive and empathetic counseling style is one of the keys to establishing a therapeutic alliance. A therapeutic alliance is very important because the clinician can express empathy that enables clients and families to begin to recognize their own feelings. This is an essential step in managing them and learning to empathize with the feelings of others. Clients and families with co-occurring disorders usually have lower motivation to address either their mental health or substance abuse problems. They have greater difficulty in understanding and relating to other people and need even more understanding to support to make a major lifestyle change, such as adopting abstinence from substances. Support and empathy on the clinician's part can help maintain the therapeutic alliance, increase the client's family motivation, assist with their medication adherence, model behavior that can help the client and family build more productive relationships and support the client and family as they make a major life transition. Using an empathetic style. We communicate respect for acceptance of the client and families and their feelings. We encourage a non-judgmental, collaborative relationship. We allow the clinician to be supportive and a knowledgeable consultant. We compliment and reinforce the client family whenever possible when they make progress. We listen rather than tell. We educate with the understanding that the decision to change is a part of the client and family and not the clinician's decision. We provide support through the recovery process. Developing empathy through family involvement. To work effectively with persons from various cultural groups, the provider should learn as much as possible about the characteristics of the particular cultural group as the client, such as their communication style, how they relate to each other interpersonally, and the expectations of the client and the family. We include the family members in celebrations of success for the client and family and for themselves. We're going to talk a little bit about motivational interviewing developed by Miller and Rollinick in the early 80s. Empathy is the first part of motivational interviewing. So what we do in motivational interviewing is the first thing we do is we learn to develop discrepancy. And developing discrepancy is when the client tells us something that's controversial to what they should be doing on their treatment plan. In other words, they could say, I used last night and I really feel bad about it and I missed my curfew and now I'm on lockdown in my home for 2 weeks. So instead of shock when the client tells us that they relapsed or scolding them when they've told us they've relapsed, we could say to them, developing discrepancy, well, it seems on one hand that you are upset by being on lockdown and how you used, and that takes a big toll on your freedom. Then we could do a motivational interviewing technique. That's the second one, which is expressing empathy. Would be the similar scenario. I see that you're really concerned about how you relapsed and how that's affected you. We could amplify their ambivalence if they showed that they didn't care. In other words, if they said, well, I just relapsed, everybody expected me to do it. We could say, well, it sounds like you know that everybody expects you to relapse and that doesn't bother you too much. That's amplifying ambivalence. Rolling with resistance is if they are unable to change. We have to look at what this means to them, the inability to change. Well, I'm an addict and everybody calls me an addict, so I might as well use. Well, it sounds like you've kind of labeled yourself as being an addict and that's how you feel about yourself and you really want to use. So why don't you tell me what using means for you? And then we can support self-efficacy. Supporting self-efficacy is when they make positive changes. Well, they could say to us, well, I've had a period now where I haven't used and I've been getting closer to my higher power and I'm starting to feel better about myself. My faith is increasing. Wow, it sounds like you've really had a period of enlightenment that's helping you with your recovery. That's how we support self-efficacy. So in developing discrepancy, the client and family, rather than the counselor, should present the arguments for change. Change is motivated or perceived as a discrepancy between the present behavior and the important social goals or values. Use scaling and a decisional matrix techniques. We kind of use the Columbo approach. For expressing empathy, acceptance facilitates change. Skillful, reflective listening is fundamental. Ambivalence is normal. Empathy, the next motivational interviewing style, recognizing and verbalizing where the client is of two minds. That's amplifying ambivalence. It's diametrically opposed to the other. So one mindset being, well, I wish I could stop relapsing, but I really identify as being an addict. So there's a part of recovery where the client is trying to figure out how they can move towards recovery, and they're still identifying with using or old using behaviors. That's when we tend to work on amplifying ambivalence as one of our motivational interviewing techniques. This helps the client move towards change. Rolling with resistance, sometimes we have clients that really don't want to change. So then we will avoid arguing for the change. Resistance is not opposed directly, but indirectly. New perspectives are invited, but not imposed. The client family is a primary resource in finding the answers and solutions. Resistance is a signal to respond differently. It's a 180-degree shift. So when we support self-efficacy, the fifth motivational interviewing technique, we learned that a person's belief in the possibility of change is an important internal motivator. The client family, not the counselor, is responsible for choosing and carrying out that change. The counselor's own beliefs in the person's ability to change becomes a self-fulfilling prophecy. So for success of motivational interviewing with co-occurring disorders, we have to apply motivational interviewing techniques to client and families with co-occurring disorders. We do this in exploring the client's family understanding of their clinical condition. We ensure the client's family attendance at initial sessions. We expand the client's family assumptions of their responsibilities for change. A lot of times, clinicians can develop countertransference or transference issues. And countertransference is the complex feelings of a psychotherapist towards a patient. The concept of countertransference is usually useful for understanding how the clinician's past experience can influence current attitudes for a particular client family. So what happens is you may have a client that may remind you of someone in your own life that you didn't have a good or positive history with, and that can give you some feelings of countertransference. In those situations, it's best to talk to your supervisor about those feelings. How do you manage countertransference? So inexperienced clinicians are often confused and ashamed when faced with feelings of anger and resentment that can result from situations, and they kind of clam up about them. They don't talk about them. They're less experienced and may have more difficulty identifying countertransference and accessing feelings evoked by interactions with a client family, naming them and working to keep these feelings from interfering with the counseling relationship. Once this was considered a technical error, but countertransference is now understood to be part of the treatment experience for the clinician. Particularly when working with multiple and complicated problems, clinicians are vulnerable to the same feelings of pessimism, despair, anger, and the desire to abandon treatment with the client and family. So there are some countertransference challenges. Counselors may find some client families have preconceived mindsets about mental illness or severe substance use disorders that may result in counterference challenges. They may be threatened by therapy. This is important to understand and recognize certain patterns that invite these feelings and not let them interfere with the client-family treatment process. What is transference? Transference describes the process whereby the client and family projects attitudes, feelings, reactions, and images from the past onto the clinician. Maybe they didn't have a good clinician prior to you. Maybe they feel that everybody has let them down in the system. These are common countertransference problems. And the client and family may regard the clinician as the all-authoritative father, the know-it-all older brother, or the interfering mother. And if so, then we have to re-educate our client and family on how the process works in recovery as a partnership. Cultural issues may arouse strong and unspoken feelings and therefore generate transference and countertransference. Although counselors working with clients' families may be in their area of expertise, the family is in their area of expertise with their cultural issues. So that's one thing where the clinician can learn from the client. It's important to ask questions about culture, to understand their culture and some of the mindsets around drugs and mental illness. How do we provide and manage adversity? Individuals with co-occurring disorders often experience demoralization and despair because of the complexity of having two problems and the difficulty of achieving treatment success. So we should inspire hope, often in the necessary precursor for the client and family, to give them short-term relief in exchange for long-term work, with some uncertainty as the time frame and the benefit. So developing small goals that are very attainable for the client family and encouraging them to meet and succeed in those goals will help manage the adversity. We should employ some culturally appropriate methods. Listen to the stories and myths that the client has to tell you or the family has to tell you about their culture. Understand some of the symbolism in their culture. There may be power structures in their culture, organizational structures, control systems, ritual and routines. This is the paradigm for employing culturally appropriate methods. So how do we obtain a cultural history? C, culture. What specific culture does the client family identify with? Simply ask them. U, understanding. How does the culture affect the client family life? L, limits. Are there cultural beliefs that place any limits on your interactions and participation in treatment? T, traditions. What are your cultural traditions that you practice? U, unique. What practices does the client and family identify with as unique in their culture? R, responsibilities. Assess the level of cultural responsibilities for both the client and the family. E, education. How does the client family practice culture to enrich your cultural acuity? Cultural competence. We have to assess the client, the family, and the family's identification with their ethnicity. We need to assess the client's family identification with their spirituality and their religion to help them determine what values and traditions they can use to help shape their recovery. In review, we use culturally competent methods for family engagement. We take the cultural context, background, and experience into account in the evaluation, diagnosis, and treatment of the families from various groups, cultures, or countries. We recognize the importance of culture and language, acknowledging the cultural strengths of a people group. We adapt services to meet the unique needs and value systems of persons in all groups. We expand and update our own cultural knowledge, and we work on stigma reduction within a culturally sensitive approach. To give you an example, I've had several clients in my private practice for various things where they've gotten in trouble with the law, and because of their culture, they do not want their family to know. One time I had a young woman that was Islam, and she was celebrating Ramadan and had to go back to her family, but under the constraints of her probation, she could not go back. So she was fine with telling them that she had to work. She didn't want to tell them about her current probation because that would be having her family look down upon her, and she was not ready for that. So she worked through the Ramadan holiday instead of going to see her family in another state. How do we increase support and structure? Contingency management is a good way to increase support and structure within a client and family group. Obtaining their spiritual history and giving them key techniques for success. Contingency management with clients and families is something that can be used when a form of behavior can be altered. When we see something that's a stumbling block for our client or our family, and assuming neurobiological and environmental factors can influence substance use behaviors, we have to be consistent with reinforcing environmental consequences that can change these behaviors. So the clinician arrangement for regular drug testing is in fact contingency management, because it's something the client and family can rely upon to ensure the client's non-use or use of a targeted substance and its early detection. The clinician can provide positive reinforcement when abstinence is demonstrated. These positive reinforcements are agreed upon mutually. It could be a day out of a group. You don't have to go to group. If you maintain abstinence for a period of 3 weeks, then you can take one group off per week. The clinician withholds the designated incentives from the individual when the substance is detected. So whatever the designated incentives are, and they can be worked on within the family. Maybe the family wants to celebrate a milestone, but the client doesn't make that milestone, so they hold off on celebrating those incentives, and they choose something to help the client move forward with a new incentive established. The clinician and family establish healthy activities. If contingency management is not meant, it's not a punishment. What it is a way of reevaluating and looking at what's a healthier choice for this person. So some contingency management techniques that clinicians and drug alcohol treatment facilities use are drug abstinence, clinic attendance and group participation, medication adherence, following the treatment plan, attaining goals. The clinician may use a variety of contingency management techniques or reinforcers. Common are cash vouchers, prizes, retail items, and certain privileges. I'd say for the cash vouchers and prizes, that's contingent upon your agency. Cash could be in the form of paying half price for a session instead of being charged full price. It could be vouchers, gas cards, gift cards to Dunkin' Donuts. Prizes, it could be a goal attainment certificate or an achievement certificate. And retail items could be anything that the client could earn, maybe a knapsack full of healthy treats. And certain privileges could be that they have certain privileges within their residential setting. They're allowed to stay out longer at night or go home on weekends, whatever those privileges may be. So how to design a contingency management program is choose a behavior, focus on one that is quantifiable and occurs frequently and is considered to be important, and set reasonable expectations. So in other words, if the person is relapsing continually prior to going home and not and then having that past taken away from them if they're in a residential setting, that's saying something. We have to tease out then what the client is going through when they go home. Maybe they're going into a family environment that is negative for them, so they're self-sabotaging. So then we have to choose a positive reinforcer. So what can we do instead? You know, what can they do to achieve sobriety? Maybe giving them a goal in the residence instead of going home for the weekend. Maybe that's what this person needs. And identify intangible rewards, such as frequent positive rewards and in the form of reports to parole officers, flexibility in methadone dosing, or increasing freedom, smoke break, passes, etc. Use behavioral principles, develop monitoring and reinforcement schedules that's optimized through the application of behavioral principles. Keep a schedule simple so staff can apply the principles consistently and the clients can understand what is expected. Prepare a behavioral contract. When contingencies are in the form of behavioral contracts, it's usually when you're addressing a certain client behavior. So you draw up a contract to target the behavior and consider the monitoring system and reinforcement schedule. Be specific. Consider alternate interpretations. Have others review the contract and comment before giving it to the client. Include any limitations. Implement the contract. Ensure a consistent application of the contract. Devides methods of seeing that staff understand and follow the procedures. Remind the client about the behaviors and the consequences and their account balance of what is required of them to obtain a bonus to increase the probability of escalating the reward system that will have a desired effect. So now it's important that we attain a spiritual history. The spirit is the body plus the mind plus the spirit equals you. So spirit, we look at the S, a spiritual belief system. This is simply asking the client, do you have a spiritual life that is important to you? Do you have a formal religious affiliation? What is your clearest sense of the meaning of your life at this time? The P is the personal spirituality. When you are afraid or in pain, how do you find comfort? Describe your beliefs and practices of your religion that you personally accept. In what ways does your spirituality or religion is meaningful in your daily life? The I, integration with your spiritual community. Do you belong to any religious or spiritual groups? How do you participate in these groups? In what ways are these groups a source of support for you? The R is for ritualized practices and restrictions. What lifestyle activities or practices does your religion encourage, discourage, or forbid? What meaning do these practices hold for you? To what extent do you follow these practices? I is implications for medical care. Would you like to discuss religious spiritual implications for your health care? Are there specific elements of health care that your beliefs and religions discourage or forbid? T is for treatment planning. What values can you gain from your religion or spirituality? How can they help you in your life goals? This is a really important question. How can they help you in your life goals, and how can they help you in your treatment planning goals? Key techniques for success in working with clients with co-occurring disorders is number one is support. Provide motivational enhancements consistent to the client family's specific stage of change, as we saw earlier. Design a contingency management program that addresses specific targeted behaviors. Use motivational interviewing techniques. Use relapse prevention techniques. There is an attached plan in your handouts. Use repetition and skills building to address deficits in functioning. Facilitate client-family participation in mutual self-help groups. So now we're going to go over the addendums: suicidality and depression, domestic violence, and how to report abuse. Suicidality. Suicidality is the 10th leading cause of death overall in the USA. In the state of Maine, where I live, it's the first leading cause of death for ages 10 to 14 and the second leading cause of death for ages 15 to 30 and the third leading cause of death for ages 35 through 44. So there are some behavioral indicators and circumstantial indicators of suicidal risks. Do they talk about committing suicide? Do they have a lot of trouble eating or sleeping? Have they had drastic changes in behavior, withdrawal from friends or social activities, loss of interest in hobbies, work, or school? Do they prepare for death, such as making a will or final arrangements? Do they give away their prized possessions? Do they have a history of suicidal attempts? Do they have unnecessary risk-taking activity? Do they have recent severe losses in their life? Do they have a preoccupation with death and dying? Do they have a loss of interest in their personal appearance or an increased use in alcohol and drugs? There are some expressed emotions that indicate suicide risk. I can't stop the pain. I can't think clearly. I can't make decisions. I can't see a way out. I can't sleep, eat, or work. I can't get out of depression. I can't make the sadness go away. I can't see a future without a pain. I can't see life as being worthwhile. I can't get someone to help me. I can't seem to get out of this depression. So for suicidality and depression, we obtain a mental status examination to evaluate the client's family overall mental health and danger profile. We ask questions about the client family symptoms and use of medications and look for signs of mental disorder regularly. We keep track of changes in symptoms, and we ask the client family directly and regularly about the extent of their depression and any associated suicidal ideations. The SBQR questionnaire is a very simple four-question questionnaire. That's a lot to say. 1, have you ever thought or attempted to kill yourself? 2, have you ever thought about killing yourself in the past year? 3, have you ever told someone that you are going to commit suicide, or have you had an instance where you might do it? How likely is it that you will commit suicide someday? So the scoring for that and the interpretation is in your addendum, and you can use that as a suicide risk questionnaire for parents who you might consider to be suicidal. The next is exploring domestic violence situations. We always interview patients in private about domestic violence, never in the presence of family. We begin with direct, broad questions and move towards more specific ones, inquiring how disagreements or conflicts are resolved. Do you want to hit them to make you see any sense? Ask, that's the case of a perpetrator. Ask whether patients have trouble with anger or could have had anything when angry that they regret. Combine these questions with other types of lifestyle questions. There's a domestic violence questionnaire as an addendum in this packet. Please feel free to use it. It's on intimate partner violence. Ask about violence by using concrete examples and specific hypothetical situations rather than vague conceptual questions. Display information about domestic violence and help in public, such as in restrooms, in the hallways of treatment centers. Have pamphlets readily available. Tips for screening for domestic violence. Look for physical injuries, especially patterns related to unretreated injuries to the face, neck, and throat. Pay attention to other indicators, history of relapse or treatment noncompliance, inconsistent explanations for injuries and evasiveness, complications in pregnancy, possible stress and anxiety-related illnesses and conditions, sad, depressed affect, or talk about suicide. Fulfill legal obligations to report suspected child abuse, neglect, and domestic violence. Never discuss a patient without the patient's permission. Understand which types of subpoenas and warrants require that records be turned over to authorities. Convey that there is no justification for battering and that substance abuse is not an excuse. Contact domestic violence experts when the battery has been confirmed. How to report child abuse. All states require mandatory child abuse reporting for professionals and outpatient treatment staff, particularly state licensed physicians, therapists, nurses, and social workers. Most states require that this reporting be immediate and offer toll-free numbers. Most also require that the reports include the name, address of a patient or caretaker, the type of abuse or neglect, the name of alleged perpetrator. Failure to report indications of abuse that results in injury to a child can lead to criminal charges, a civil suit, and loss of professional license. Mandated reporters generally are immune from liability for reports made in good faith that later are found to be erroneous. Staff members who suspect domestic violence should investigate immediately whether a patient's children have been harmed or not. Inquiries into possible child abuse can occur only after notice of limitations of confidentiality. So that's duty to warn. Know your state's duty to warn, and make sure you go over that in the intake process with your client. Spousal or partner abuse. Generally, if a patient believes that he or she is in imminent danger, the treatment provider should respond to the situation and, if necessary, suspend the screening or assessment interview to get the patient to a local organization for help with these issues. The statewide toll-free number is listed. If you are deaf of hard of hearing, this is the listing. And if you have a video relay system and a provider, you can call that. If you are in immediate danger, you call 911 or your local police department. Integrated treatment is the most effective approach for treating co-occurring disorders. This is outlined in the Hazelden curriculum on co-occurring disorders. Research shows that integrated approach to treating co-occurring disorders results in the best possible patient outcomes. The integrated treatment model addresses the problem by ensuring that one visit in one setting is sufficient to receive treatment for both mental health and substance use disorders. In other words, they don't have to go to two places to treat their mental health and substance abuse, but they can choose to. Key features of integrated treatment are now considered evidence-based practice because it has been shown throughout multiple randomized controlled trials to be more effective than other approaches. There are several key features of integrated treatment services. Shared decision-making. Shared decision-making is a systematic approach to client-centered care that involves the client explicitly in the treatment process. In this approach, clients with co-occurring disorders decide what goals they want to pursue, how they want to proceed with treatment, and what their path to dual recovery will be. The integration of service when both mental health and substance abuse services are provided by the same person or team, the client has one treatment plan, one set of goals, and one relapse prevention plan. The process of communication across agencies disappears. There is the assertive community outreach approach. Many people with co-occurring disorders do not come into mental health centers to seek treatment on their own. They might be on the streets, in homeless shelters, in police custody, in jail, or in prison. Assertive community outreach uses that specific engagement strategies to necessarily connect with them for the help they need. This can include outreach and case management services, referral to treatment, seeing a recovery coach in the community. Reduction of the negative consequences. Before people are ready to completely stop using substances, they're often willing to take smaller steps to reduce some of the harmful consequences of use. This is when assertive community outreach is important. They're not ready to change yet, but they will contemplate that change. Comprehensiveness. People with co-occurring disorders typically have multiple needs. They have two illnesses which can be both demoralizing and can reduce a person's basic psychosocial supports. Co-occurring disorders programs, therefore, must have an array of services. These include housing, case management, supported employment, family, psychoeducation, social skills training, illness management, and pharmacological treatment. In a reduction of negative consequences happens when before people are ready to completely stop using substances. They are often willing to take smaller steps to reduce some of the harmful consequences of their use. When people progress on some of these harm reduction goals, they become more motivated to control their substance and mental health disorders. Some professionals argue that this approach enables an addicted person to continue to use, and because of this enabling, addicted persons will never experience the pain of their use and hit bottom so they can truly recover. For people with co-occurring disorders, however, not attending to negative consequences of addiction often leads to death. Taking positive steps to increase motivation for recovery comes in the process of using the harm reduction technique. So there's some effective co-occurring screenings that you can use, and these are the Family Engagement Checklist, the Modified Mini Screen, the Mental Health Screening Form, the CAGE, adapted to include drugs, the CAGE Aid, the SSI-AOD, Simple Screening Instrument for Alcohol and Other Drugs, the Suicide Depression Scale, the PTSD Checklist, and the Social Interaction Scale, and these are included in your homework. So effective therapies for families with co-occurring disorders, we have heard, are motivational interviewing, cognitive behavioral therapies, contingency management, integrated family therapy, Hazelden Co-occurring Disorders Program. Now, the Hazelden Co-occurring Disorders Program is listed here, but is used for purchase by Hazelden. So you can purchase these through Hazelden, and they will send them to you, and these are effective tools for treating co-occurring disorders. So now it's time for your homework. Please answer the following questions for your case scenario. So I need you to pick one case scenario. What types of screenings are needed for the patient and family? You can also use the cultural competency screening provided in this PowerPoint slide and the spirituality screening provided in this PowerPoint slide. What are the problems that you, the clinician, will be treating for both the client and the family? What therapies will you utilize? What are some potential barriers that this client and patient will face during the recovery process? So I need for you to summarize that in paragraph form for each scenario, and then send it back by email to Jennifer Vitkus at the ACCA, and then you will be able to get your certificate. If you need any questions answered, you can contact Jen, and she can give you my email address, and I will be happy to answer any questions about your homework. It's been wonderful spending this time with you to learn more about co-occurring disorders.